Hi again. I'm Dr. Lugo. I'm one of the pediatric endocrinologists from the Morris Children's Hospital in Orlando, Florida. Today, I will be talking very briefly about the most common growth pathologies that can be found while doing a pediatric clinical exam. So, this talk will be focused on a general overview of insulin growth factors and overall functions. Although there are many types of insulin growth factors, I will be focusing only on IGF-1 and IGF-2. I will also discuss undergrowth and overgrowth conditions in another video. So I would say that if you're a medical student or you're a medical resident and you want to focus on high yield material for your boards or your pediatric endocrine rotation, you can go ahead. You can skip this one. It's okay. I won't even notice. And you can go ahead and click on the undergrowth and overgrowth presentations. This is mostly because I'm going to discuss the molecular level of this and the clinical implications. If you're still interested and you want to just stay with us, that's perfectly fine as well. So let's move on. This image provides a general idea of the most common insulin growth factors, or IGFs. There are multiple types of insulin growth factors. They all participate, of course, in growth and function of every organ in the body. Although this talk is going to focus a little bit more in the clinical aspect, I do want to talk about this because this is important for the research world, as therapies can now be targeted to a molecular level. It is very interesting to know what happens between insulin, IGF-1, and IGF-2. And you can appreciate in this picture all the multiple interactions between them. Insulin is able to work mainly in the insulin receptor when we encounter carbohydrate or sugar in the bloodstream. However, insulin can also produce an effect in IGF-1 receptor. So this is very important to know because if you have an infant of a diabetic mother, basically what you're saying is that there was insulin that was produced in excess during these pregnancies, mostly because they wanted to meet the high sugar levels that the mother had and got transferred to the fetus. So the fetus was producing excess insulin to kind of catch up with this increased hyperglycemia. In turn, this insulin is also going to interfere with IGF-1, leading to a child that would be bigger, or known as large for gestational age, or LGA, or macrosomic. They will also continue to produce insulin after birth, and these are kids that we need to monitor in the NICU or the well-child baby unit because they have a higher risk of hypoglycemia. Another good example is to think of diabetes or new onset type 1 diabetes. Insulin is low, and so you have high sugars, but you also have deceleration in growth because you're missing that insulin. And so as soon as I provide proper insulin administration, we often see that our children improve, such as the picture to your left. So they will also have an increase in weight and an improvement in their linear growth. Keep in mind that IGF-1 and IGF-2 have a very similar homology with proinsulin, so they can trigger insulin release. And this is why we talk to them as insulin-like growth factors, which were discovered in 1957 by Salmon and Donahue. I will talk a little bit more about IGF-1 excess in children that have gigantism a little bit further on. Now, I also wanted to touch base with this because failure to growth or failure to produce this IGF-1 due to deletions or mutations in the growth hormone receptor gene, they can result in a failure to generate IGF-1 and result in conditions like Laron syndrome, which was previously known as Laron dwarfism. Now, something interesting in these cases, when there are deficiencies or complete absence of IGF-1 production, is that they have lower risk for developing diabetes and cancer. So if you'd like to read a little bit more about Laron syndrome, there is a community in Ecuador that has been followed for over 30 years. Another example of a mutation or pathogenic variant is in IGF-2. IGF-2 pathogenic variants can lead to overgrowth, like Beckwith-Wiedemann, but they can also result if there's a failure in conditions like Russell-Silver syndrome. And I will be discussing these conditions shortly. Out of all the insulin growth factors, IGF-1 is the most common that we examine in pediatric endocrinology. 75% of it is produced, of IGF-1 is produced by the liver. The rest of the IGF-1, which is around 25% of it, is of course in bones, cartilage, central nervous system, kidneys, ovaries, basically everywhere else. Now, this is very important because, and I often put this picture of Harry Potter, is because if we know that IGF comes mostly from the liver can be affected in patients that have psychosocial short stature. Psychosocial short stature is a disorder of growth failure in which you have, or you could have, or you do not necessarily have delayed puberty. But you can found in children that have pathologic psychosocial environment with or without emotional deprivation. As soon as you take them out of this environment, you will often see a catch up. Now, this is not necessarily related to malnutrition. You can also see them in patients that have been adopted or have been removed from hurtful environments. Patients with psychosocial short stature will show a recovery of IGF-1 levels as soon as they're changed from this harmful environment. There was a case, a very difficult case, a couple of years ago. So if you would like to read a little bit more about this, you could see David and Louise Turpin House of Horrors. And you can learn a little bit about how these patients, even though they were already adults, they were having problems with their linear growth and their development. Now, this is going to be continued in future conversations about undergrowth and overgrowth. If you do have any questions or you would like to provide me any feedback, please reach out to me at my email. And I'll see you guys later.